have some fatigue with continual lectures like that, so but we're all used to it as medical students and as doctors, so try to be alert. Even me, I'm trying to be alert. Praise the Lord. So we thank God for this opportunity to give this that many have given their own parts. So let's do this. So we'll be discussing evaluating a patient with bleeding per rectum. It's a very important subject because as medical students, doctors, all of us get to collect patients or patients come to us. Sometimes with this complaint and sometimes with other complaints, but they have this complaint. This may not be a primary complaint for them. And we are being taught to review systems. We are being taught to ask all the questions. That's very important that when we see a patient that has this complaint, that we take time to know what is happening. Because blood is not supposed to be passing through the rectum, isn't it? It's an abnormal thing that blood is passing through the rectum. So let's give some introduction. What is bleeding per rectum? So it just simply means passage of blood through the rectum. Okay? Sometimes you wonder why it's not bleeding per annum or something, but mostly maybe because the source of the bleeding, as it was taught, that is coming to the anus is from the rectum. So it's being said bleeding per rectum. It does not mean that the blood is emanating from the rectum. It can actually be from all of the GI tract, even from the even swallowed blood, even from the mouth. You swallow it, can get altered and it will come out through the stool. So bleeding per rectum is blood that is coming through the rectum from all parts of the GI. So the blood can be in any form. It can be obvious and it can be obscure or occult. Obvious means you are seeing blood. It could be bright red, it could be altered, and then it could also be occult. There's no evidence, physical evidence of blood, but microscopic evidence will be there. Okay? So sometimes it could be melena when the blood has, the red cells have been digested, and then it becomes dark and mixed with the stool. So that could be the presentation of bleeding per rectum. Okay? We classify bleeding per rectum, or we classify GI bleedings traditionally into upper gastrointestinal bleeding and lower gastrointestinal bleeding. And the ligament of Treves, that's the junction between the fourth part of the duodenum and the jejunum, as the cutoff point for upper GI and lower GI. Okay? And sometimes, traditionally also, it's been added that there is obscure bleeding. Obscure bleeding means bleeding that has not been diagnosed following upper GI endoscopy or colonoscopy. Okay? So that has been understood before now. Now, currently, the definition is changing because of the armamentarium of diagnostic things that we have, okay? Equipment that we have, like visual capsule endoscopy, CT angiography, CT enteroscopy. All those things are newer things that are available, though we don't have them in our own local environment, but we're international people, isn't it? And we need to know about that. So based on that, the classification is changing. Upper GI endoscopy, upper GI bleeding now refers to the bleeding that is emanating from that part of the bowel that upper GI endoscopy can be able to diagnose. So from the esophagus, from the stomach, and then from the duodenum up to the ampulla obverta. Then small bowel bleeding is the one that's emanating from the ampulla obverta all down to the ileocecal junction. Now there are investigations that can give us these sites that the blood is coming from the small bowel. So we can classify that separately. And the pathologies that cause those bleedings are also different. So that is important for us to know that this is from the upper GI, we can reach it through upper GI endoscopy, or this is from the small intestine, we can diagnose it through these diagnostic measures, and they have their different interventions. Then colonic bleeding, of course, is the bleeding that arises from the colon, and most of those bleedings we can be able to access them and diagnose them using the colonoscope that we do have. So then the obscure bleeding is also still another form of what? Classification, because in it, after doing all those investigations, you still would not be able to pinpoint and say this is the site of the bleeding. So that's important to note that. Okay, so a brief epidemiology, about 170 cases per 100,000 in adults, and it's actually increasing in age. That's for the whole of the GI bleeding, either upper or lower. And from the definition, we know that bleeding per rectum does not mean that the blood is coming just from the lower GI. Even though in most of this presentation we'll discover that we'll be discussing most of the lower GI causes. All that. So it's estimated incidence of 33 to 87 per 100,000 for the lower GI. Actually, we know that the upper GI bleeding, the incidence is higher compared to the lower GI bleeding. Some studies equate it 5 to 1, and some about 4 to 2 or 3 to 2. Okay, so for lower GI bleeding, we know that it increases with age. As the patient's age, there is an increase in the incidence of lower GI bleeding, and that. Okay, so 95% of lower GI bleeding is from the colon, and then just about 5% or less is from the small intestine. Okay, increasing with age, as we said, 95% of lower GI bleeding. Yeah, okay, 3% of emergency surgical referrals are due to lower GI bleeding. Okay, so lower GI bleeding can present as elective and it can present as an emergency. That we should know. Okay, and other forms by which we can classify is based on the presentation. It could be acute, chronic, or massive. Massive is also a form of an acute presentation of lower GI bleeding. However, we want to separate that differently because of what it presents to the doctor. The kind of challenge in management, in treatment that it presents to the doctor, massive is usually considered separately. And what is massive lower GI bleeding? It is any lower GI bleeding or any GI bleeding that has an attendant what? Hemodynamic instability. The patient goes into shock, or patient goes into shock, or is not responding to your resuscitative intervention. Okay, and sometimes we also classify them based on the anatomic regions where the bleeding is coming from: anorectal, rectosigmoid, proximal colonic, or the right side of the colon, and then left side of the colon, then small intestine, and then other forms of the bleeding. What are the etiologies for this lower GI bleeding? Mostly benign anorectal conditions like hemorrhoids, fissure, rectal prolapse are the things that we commonly see as causing lower GI bleeding. Diverticular disease is the most important cause of acute or massive lower GI bleeding or bleeding per rectum. So sometimes you'll be seeing me interchanging lower GI bleeding and bleeding per rectum. So you know that from what we have explained before now. So diverticular disease is very, very important. It's not so common in this environment, but it comes. And when it comes, you need to know and you need to be prepared, because that is something that will have to keep you on your toes. If not, you will lose that patient, because the bleeding can really, really be massive. Okay? Angiodysplasias, intravenous malformations, anticoagulant therapy, colorectal cancers, polyps, all that are some of the causes of lower GI bleeding. And so when we evaluate a patient with bleeding per rectum, we're trying to see, is any of these the cause of bleeding per rectum or what? Because we said that blood through the rectum is not a normal route for it. So we need to find out why there is blood coming through the rectum. Okay? Some could be colitis, some could be post-pelvic radiation therapy. There are a lot of cancers now, people are managing it through radiotherapy, bleeding can ensue following radiotherapy, maybe patients with prostate cancers, cervical cancers, and the rest of them. Okay? Undiagnosed, some of them cannot be diagnosed, just like we said, obscure bleeding. Okay? And, a study in UK even quoted this figure very high, up to 23% of admitted patients, they are not able to find the cause. If they're able to do this, to get up to that, I wonder how our own data would show that. Okay. Yeah, so based on the regions, there are some of the diseases that cause this bleeding. Hemorrhoids, acute fissure, distal colitis, rectal prolapse, some of the rectal causes, rectosigmoid, rectal tumors, proctocolitis, the particular disease, proximal colonic, infections like dysentery, schistosomiasis, lymphogangloma venereum, tumors, inflammatory bowel diseases, the particular diseases, and even hemangiomas, angiodysplasias, doulafoil lesion, which can occur in the upper GI and in the lower GI. All of that are some of the causes there. In the small intestine, GI bleeding or rectal bleeding can be ensuing from there. Enteric fever, which is really one of the commonest causes of GI bleeding in children, especially in our own environment, where there is a lot of hygiene problems, and then patients come down with enteric fevers. Okay? Tumors, angiodysplasias, doulafoil lesion, as you said. Upper GI bleeding can be a cause, as has been mentioned, of bleeding per rectum. Others can be bleeding diastasis or anticoagulation. So patients are anticoagulants, and then they will have bleeding per rectum just because they are anticoagulants, and not really because there is a specific pathology there causing the bleeding. NSAIDs, people abuse NSAIDs a lot, okay? And we can go over the counter and get these drugs at all times, and this could be the reason why they are having bleeding. So all this, a patient being evaluated for bleeding per rectum, this needs to be in our minds, and we should be able to get to diagnose that. Okay? Massive lower GI bleeding, the usual cause are bleeding from the upper gastrointestinal tract. I hope that doesn't confuse someone. So, duodenal ulcers, gastric ulcers, diverticular disease, varices, hemorrhoids, enteric fever, angiodysplasias, amoebic colitis, all these cause massive or can cause massive lower GI bleeding. Lower GI bleeding that would require a patient to be resuscitated and transfused. Okay? Uncommon causes, inflammatory bowel diseases, colorectal cancer. It can cause massive lower GI bleeding, but it's not as common as those listed above. Polyps, patients with familial adenomatous polyposis syndrome, they have a lot of polyps, in excess of 100 polyps in the GI. They can actually bleed and have massive lower GI bleeding. Okay, hemangiomatas, doulafoil lesions too. In a doulafoil lesion, just a less than 1 centimeter lesion in the intestine. That lesion, if it's sitting on an artery, a big vessel, what will happen? It will just keep pumping blood, and the patient can come down with massive lower GI bleeding. So that's important. So let's not forget the children, infants, necrotizing enterocolitis, intussusception, fissures, allergic colitis. All this can cause lower GI bleeding in children. Anal fissures, gastroenteritis, typhoid ileitis, juvenile polyps, Merkel's diverticulum are some of the causes that we have there. How do we evaluate these patients? We have general principles in evaluating patients with lower GI. Okay? Our evaluation is to what? Arrive at a diagnosis, to find from the causes that we have listed prior to this slide. So accurate diagnosis of that will rely on what? Prompt resuscitation, because the patients can come as massive lower GI bleeding with hemodynamic instability. Then you also need to have an initial risk evaluation of that patient. Is that patient going to bleed again? Or is this bleeding, has it caused some life-threatening thing that patient needs an emergency intervention? It could even mean surgery an emergency surgery, and then it could also mean an emergency intervention, like some kind of radiological intervention. Radiologists can intervene in the emergency setting to stop those bleeding. Then provisional clinical diagnosis needs to be made, okay, before we now move on to definitive diagnosis, following investigations that help us to localize the site of this bleeding and then provide specific interventions. So with this in mind, you should be able to evaluate such a patient, okay? So the presentation, how do they present? They can present in an emergency setting with massive lower GI bleeding, or in the elective setting with overt bleeding per rectum. Overt is something that you will be able to see and know that this is blood, okay? Then it could be occult or it could be obscure, as we have mentioned and defined these terms before, okay? Some of them will present unstable, okay? That's another way of stating it. Unstable patients. Now, when you do the shock index is very simple. We hardly do it, but it's very simple. Just divide the pulse rate over the systolic pressure of the patient at that time, and can change, because as you evaluate the patient continuously, it can change. So any shock index that is less or equals to 8, that you will be okay. That is more than 1. I'm still on that. That patient is unstable, and that patient needs continuous monitoring and then continuous intervention that will bring resuscitation, or that will resuscitate the patient. Okay? So for the stable ones, it could be major and it could be minor. It is the Auckland score of less than 8 that divides it. The Auckland score tries to group patients that are stable with scores, different scores, and tries to give you to know that this is a major bleeding or this is a minor bleeding, and whether the patient needs to get further interventions immediately, or you need to send the patient for further evaluation in the event that you don't have the armamentarium of investigative measures to diagnose the bleeding at that time. Okay? So other forms of presentations could be the patient is presenting with just features of anemia, chronic anemia the patient has been having, cachexia, other GI symptoms, change in bowel habits, and the rest of them. Okay? Symptoms of chronic liver disease and all that. All that should actually give us that high sense of how do they say it? Suspicion of saying we should check the rectum. Is there something also ensuing from that? So that's very, very important to do that. Okay? So in the resuscitation, we know that once the patient is hemodynamically unstable with a shock index of more than 1, you need to follow the ABCD of resuscitation. We're not going to go into this because it's not part of the lecture, but we know that that is very important to do. Sometimes the airway is not a problem, it's just the rectum. So you know that you could jump that and then go to the circulation where the problem is lying, and then continue with that. Okay? So risk assessment of the patient is important, and it is done during resuscitation, and onwards you keep assessing the risks of this patient. Many times when we fail to assess those risks, or we fail to manage the risks, those patients actually deteriorate, and it could even become a mortality. Okay? So one of the investigations that we do immediately during resuscitation is the hematocrit or the HB of the patient, but you know that it does not fall what? Immediately, okay? Following lower GI bleeding. Hence, serial hematocrit during resuscitation is very important. As you give fluid, you keep doing that to see the level of deficit in the blood of the patient. So that's very important. And if the bleeding is a overt bleeding and you see that there is some kind of hemodynamic instability in the patient, especially the fact that you are resuscitating and the patient is not really responding to resuscitation, you need to group and postpone the blood immediately, because when the thing goes into another phase or level, you may lose that patient while you are trying to just give fluid. Okay? We cannot continue to pump fluid into patients who are losing blood. So we need to be able to get that to them. All right, thank you. So clinical evaluation, know that history, very important, very important. I think I will not go through that. We teach our students how to take good history, checking and reviewing all the systems, history of liver disease, bleeding diastasis, previous history of lower GI bleeding, very, very important in this patient. And when you examine the patient also, the conscious level of the patient, features of anemia, very important. Some of these patients, they will be having on their cardiovascular examination, pulse rate is increasing, blood pressure is going down, but some may even be normal, and some of them may have hypostatic hypertension. They are standing, they will just want to lie down because they're having hypertension because they have lost blood. And some of them will be hypertensive even on lying down. So that is important to also get to decipher that. Okay? Then the abdomen, left iliac fossa tenderness could mean that there's diverticulitis. The last tenderness may be terry fever, abdominal masses may be there, and sometimes the abdominal examination may be what? Normal. Okay? May be normal. Yes, so you examine also the conscious level of the patient, the features of anemia, and all that. Then when you come to diarrhea, I think I want to talk more about that. This is one of the headaches or the fights I have with my students, about doing diarrhea. Medical students don't like doing diarrhea, and it's not only limited to medical students. I think some of our doctors who are in the other side, I know that surgeons do, yes, I'm a surgeon and I can say that they do diarrhea, but other doctors don't like doing diarrhea. And diarrhea is very, very important. It's an evaluation that someone can do to help a patient that is having rectal bleeding. The problem may just be there in the rectum, and you're not putting your finger. It says, there was a saying that a WAP once remarked, with considerable truth, that a consultant is a doctor who make a rectal examination. So if you want to be a consultant, even if you're a medical student, try to do what? Rectal examination. I had somebody who told me one time that they went to see a doctor. The doctor was seeing them. As they were saying their complaints, the doctor was writing drop and giving them. What kind of a doctor is this? The other one now said, I went, a doctor examined me, even put his finger into my rectum. This doctor is just good. Do you understand that? So even patients expect you to do what? To thoroughly examine them and to be able to give them their diagnosis. Okay? So rectal examination can be defined as what? That visual inspection of the perineum, digital palpation of the rectum, and assessment of the neuromuscular functions of the perineum or the anus. So once you do that, you have done what? A complete digital rectal examination. And that's very important. Every specialty in medicine should know how to do and should do digital rectal examination. Are there indications of doing it? Yes, it's a part of what? Full physical examination. It's a part of abdominal examination. If you have finished examining the abdomen and you have not done a DRE, you have not done that. You have not finished that examination. Is there any contraindication to digital rectal examination? Is there? Can anybody hazard a guess contraindication? Anybody in the group, in the house? Huh? No. Uncooperative patients. Yeah? Why should a patient decline?
Doctor without the finger. A doctor without the finger.
You should be able to. A
doctor without the finger.
So except if the patient doesn't have what?
Rectum.
So there's nowhere to put a finger. Then the next one is what he said, isn't it? If a doctor doesn't have a finger. These are the only contraindications. So when we're in medical school, they say if you don't have a finger, then you should use your toe and put it there. That's how they were hammering it to us, and we took that to heart, that we must do a digital rectal examination, and you will soon see where. So the caution is just that you should avoid what? Vigorous manipulation in infants and children, so that you don't destroy their sphincters. And then when there are painful anal conditions like anal fissure, you don't need to what? Keep causing pain to the patient. But you inspect, because inspection is what? Part of it. Okay? Then acute prostatitis, recent anal surgery, so that you don't disrupt what you have done in that part. So that's the thing. This is just a diagram to show us some of the things there where your finger needs to reach. You can see hemorrhoids, tumors can be there, and all those other things can be there. Okay, you can assess the prostate, even the bladder, by doing a bimanual palpation. Okay, the seminal vesicles too, you can be able to assess them. Okay, you can assess even fluid in the lower pelvic peritoneum. Okay, and all that. So very, very important to do that. Now, I put this slide to just show us that by just doing a rectal examination, up to about 40% of colorectal cancers, you would be able to do what? To see them. See, 38% of colorectal cancers are where? Just within the rectum. Your finger can reach them. I have some cases, maybe when I come to my last slide, I will discuss that. Okay? So, very important to do that. Optoscopy. So now investigations proper. After doing all those things, what are those other investigations that you need to do for the patient? Optoscopy is very important. Usually it's a clinical procedure and it's complementary to doing a DRA. Okay, so there you can be able to visualize the rectum. You can even see above where your finger could not reach by doing a optoscopy. And then you could also, it could aid you in doing a biopsy. Okay, so you could see, you could take a biopsy. Colonoscopy, very, very important. And we have colonoscopy now. No patient should be coming above 40 with lower GI bleeding. You have done, even if you have done DRA and you know that this is what hemorrhage, because everybody comes and tells you it's pile. Please send that patient for what? Colonoscopy. Please do that. One of the cases I'm going to talk about is one that that was not done, and the patient is at an advanced stage. Okay, so. It can be planned in the emergency setting, so colonoscopy can actually even be done in the emergency setting, okay, when the patient is bleeding. And if there is a small rebate of the bleeding, or the bleeding just stops a little, you could be able to do that, although it has its own drawbacks, okay, and is usually done for intervention, because you can intervene in those cases. It's best done electively after a bowel prep, where you can visualize the whole of the rectum and up to 10 to 15 centimeters of the distal ileum. Okay, when you have a small scope that can be able to go through. Okay, you can take biopsies, you can do polypectomies, you can do injection, sclerosants, and then you can also do electro cauterization of either polyps or tumors or diverticulum, where you want to stop the bleeding from the diverticulum. So that's the thing. The problem sometimes has been the availability and the access issues with colonoscopy. Okay, there was a national study in the UK that said only about 55% of hospitals offer routine interventional radiology in 24 hours, and then access to 24-hour colonoscopy in about 73. I don't know what's our own data in this country, but in just looking around randomly knowing, I know that we have up to about 10 endoscopists who do colonoscopy in Jos. So it's something that you can get done today, or in the least in 1 week, get a result of your colonoscopy. So no doctor should not offer this to a patient that there is a suspicion after evaluating the patient. Okay? So what's the usefulness? Diagnosis of colorectal pathologies, screening for colorectal cancers, and then it can also be as an adjunct to colorectal surgeries. Okay, when you do especially laparoscopic colorectal surgeries, you will need to do a colonoscopy to view the lumen of the colon. Okay, CT angiography. Yes, CT angiography is available wherever there is CT scan and there is a radiologist. This should be able to be done, especially if the contrast is available, except otherwise. So it is diagnostic, it is non-invasive, and it is most useful in what? In acute lower GI bleeding or other GI bleeding, because it's helpful in both upper and lower GI bleeding. So that is what one should do. Let me rush through this because of the time. It demonstrates neoplasms, vascular malformations, evidence of recent bleeding, hyperdense blood in the lumen can be seen. Then useful for directing and planning treatment. Okay, so once you want to plan your treatment or direct the course of your treatment, if you do CT angiography, that will be helpful. Okay? If it is negative because of the intermittent bleeding, it can also be repeated because it is non-invasive, and you will now get to diagnose the bleeding. Multi-detector or catheter angiography, very important, because in this kind of angiography, you can actually intervene. You can treat the disease. So a site of bleeding, And then angioembolization of the bleeding vessel can also be done. This is good that it can detect in 0.5, okay, 0.5 to 1 mil. Can I have 2 more minutes or listen to just finish up? Thank you. Okay, to do that. Okay? So the problem of the access side, the hematoma, and the rest of them. The recommendation by the American College of Radiology is that colonoscopy initially for hemodynamically stable patients with adequate bowel preparation, and then angiography in those who are what? Hemodynamically unstable with massive lower GI bleeding. So you can choose between the two. So those two are very important. Upper GI endoscopy very important because some of the causes are upper GI causes, and then flexible endoscopy can be done, especially if the patient is less than 40 and then the bleeds are minor. But colonoscopy is better because it evaluates the whole of the colon for you, where you would be able to screen that. Yeah. Then radionuclide studies, technetium 99 tagged red blood cell, very important also. That can be done where it's available. We don't have nuclear medicine much around this environment, but that's another way in which we can diagnose that. Then visual capsule endoscopy is also important. Okay, this is important. People write exams, and we're in a global village. Yes, we don't have it here, but when you read, you will discover that it's being done, and it's one way to evaluate that. Okay, so it's done in a stable patient, and the duration is about 8 to 12 hours. Okay, and about 10 to 50,000 images will just be reeled out. So you sit down on a computer and you'll be able to study all of the images, and you can pinpoint where it's coming. Then balloon enteroscopy, very important. These are enteroscopies that scan the small bowel, and so you can diagnose that. Fecal occult blood testing, very important. It's something that all of us can order here, and I think can be done. Okay? Where patient is presenting with anemia or chronic symptoms that show that equilibrium acrotomy. Is it an investigation? Yes, it is. If you cannot, and the patient is bleeding massively, you don't have colonoscopy or other things, or you can't do colonoscopy, you can immediately go in and then try to see where the bleeding is and take care of it. Okay? So more diagnostic tests that can be done: CT enterography, MRI enterography, stool microscopy, and other investigations are very, very important. Yes. So I think this is about my last slide. Thank you. So there's a 51-year-old man with painless bright red bleeding. It's occasional and small quantities. He ingests alcohol, is a known hypertensive and known diabetic, and is on follow-up. All these are real patients that I know them. So for this patient, for 6 months, he has been having that. Nobody put his finger in the rectum. He has been going to the clinic up and down, up and down. Lastly, when we put our finger, we discovered that there was a rectal mass that was already gone half the circumference of that patient. So that's a locally advanced disease already. This patient has been seeing the doctor, but just doing a DRE has not been done. And what would the patient explain? Sometimes he may not even complain. He may just say that what? That is pile, and all that. Actually, patients that have bleeding per rectum would have gone through all the levels of things, meeting people who are not medically inclined, meeting traditional medicine people, and treating themselves, even going to the pharmacy shop to get some hematinics. There's nothing they don't do. So, but the doctor that misses to do that would actually allow the patient to go to that level of disease that is not important. Okay, so the next patient is a 44-year-old man who presents for the first time with massive GI bleeding, lower GI bleeding, or bleeding per rectum. Mostly altered blood at times, red bleeds, recurrent episodes while on admission, requiring whole blood transfusions of up to 2 to 3 units. What do you think is the cause of this GI bleeding? Anybody here?
MBCI.
Huh?
Chronic liver disease.
Any other thing? Yes, diverticular disease. This was the diverticular disease. So middle-aged persons, they may never have had that. They are fit, there's nothing, but they just come down with this kind of bleeding. It's altered, so it can be coming from all of the colon. Okay, it's not bright red. So for this patient, kept having transfusion when there was an addition of when the bleeding abated a little, did a colonoscopy, saw a lot of diverticular bleeding everywhere, and then he had injection of sclerosants and all that. That was how we're able to stop this bleeding. So this happens too. Okay? This next patient, a 40-year-old mobile police officer with recurrent massive bright red bleeds per rectum. Over the last 9 months, he had blood transfusions for stabilization in 2 different hospitals before he arrived at our own hospital. What do you think would be the cause of this massive lower GI bleeding? Anybody? Yes? This was a patient of mine. After I operated him, the patient has just non-stop, being appreciative and thankful.
Giving thanks to God.
Hemorrhage. Serious bleeding, requiring transfusions. Of course, we did a colonoscopy for him and we discovered there was nothing up there but just that. So he had an hemorrhoidectomy and has gone back. So thankful. Okay? So that's it. The other patient is a 56-year-old woman, painless bleeding per rectum, strips of blood, red blood on stool, and then later associated with anal protrusion, anorexia, and weight loss. What do you think this is the cause of this bleeding? Anybody?
Colorectal cyst.
Yes, colorectal cancer. And this patient, when I was asked to see this patient, the tumor had gone circumferential. Colonoscopy could not be done because the scope could not pass through. This patient has been on admission in the hospital for some weeks. Nobody put his finger there. The tumor is just 6 centimeters from what the anal vagin. Sometimes some of those things actually even make me emotional. That, with time, if we're not careful, some people can sue, some doctors and say, I've been under your care and this has happened and you never did this and all that. I hope it doesn't get to that, but truly it's really, really not good. The hallmark of cancer care or cure is what? That you diagnose it early. Your aim of treatment will be what? Curative at that point. So it's very, very important. Please try to do that. So in conclusion, rectal bleeding is a presentation of a wide range of pathologies. As we have seen, presentation will differ. Exhaustion first when it is massive or stable patient, and then accurate clinical diagnosis is crucial. And that leads the way for the investigations that you want to do. And then there are some algorithms. I didn't want to bog us with all those algorithms. Okay? Most of us don't have it kept like this, we'll be looking at it. So if you understand, these basics, you should be able to do that, and you can check up all those algorithms by which you follow to evaluate these patients. Thank you very much.
Thank you very much, sir. Such a wonderful presentation. So we're going to take questions quickly. So we'll start with the people here. If you have any question and you're online, you can just put it on the message box. So if you have questions, let me see your hand up. We have 1 here. We have 2. Okay, we have 2 questions. So we're going to take them.
Okay, so thank you, sir, for your presentation. Thank you very much. So I want to ask, when the tumor has become circumferential, what then happens to the feces?
Okay, so circumferential does not mean that it has completely blocked the whole of the distance, but it has narrowed the lumen. Okay, it's another, but obviously that patient has some chronic features of intestinal obstruction. Okay, from your history, you could get a history of what? Passage of pellet-like stools or reduced in the caliber of stool in that patient. So from your history, you should be able to get that. So that's the thing. But if it has completely closed the lumen, then the patient will come in what? In intestinal obstruction, complete intestinal obstruction, and you will evaluate him as such and manage in that direction.
What about the advocate for age-specific colonoscopy surveillance?
Okay, yes, so that's important. So as I said in one of the slides, that colonoscopy is also a screening measure, okay, for colorectal cancer. So some protocols from 45 years or 50 years, you need to be having a colonoscopy. But that is not acceptable or is not accepted everywhere. Some said there has to be some risk certification. Does the patient have some risks from family history of colorectal cancer, or the patient is smoking, or there is an exposure to radiation or other risk factors? Then that may add to the use of colonoscopy as a screening measure for those patients, routine screening for those patients. But it's actually recommended, and it is important that from 50 years and above, you should have a colonoscopy, to screen yourself with the increasing incidence or prevalence of colorectal cancer. I hope that addresses the question. Thank you, sir.
Thank you very much. Let's clap for this. So we have done 2 other sessions. I want us to stretch for 2 minutes. We're going to the last